Hey everybody, and happy Halloween. Thank you for joining us on Halloween. I'll give a quick introduction. My name is Denis Nash. I'm one of the program managers and directors of the Department of Epidemiology. Welcome to the Department of Epidemiology seminar. First time co-hosting Redstone Global Center. So I'd like to introduce the director of the Redstone Global Center, Dr.
Guess we don't need to make the mic. I need to get out of the lights. So thanks so much. It's great to see everybody here. Appreciate you coming, and hopefully you can enjoy the chocolate on Happy Halloween. My name is Timothy Holt. I'm the chair and the director of the Redstone Global Center for Prevention of Illness here. It was a 12-year-old center. I think we're going to have a QR code display at some point, maybe at the end, to talk a little bit about. I'll talk a little bit about our center QR code. You can sign up. I think people are familiar with. The Redstone Global Center is the vision of healthy and thriving communities adapted to climate-related hazards and challenges. Our mission. Risk from climate-related hazards and challenges by research. So certainly our idea that Manya and I had today to co-host the DEPI seminar by bringing in a well-known scientist is certainly part of our mission. So I'd like to introduce Denis briefly. He is the friend at CDC. He's a distinguished professor at the City University of New York CUNY Graduate School of Public Health and Health Policy, and he's the founding executive director of that Institute for Implementation Science and Population Health. For more than 2 decades, he's combined infectious disease EPI and public health surveillance to generate practice-changing evidence, new HIV collaborations in the US and globally, and launched Facing COVID and Project Effects in a small online cohort study, as well as being principal investigator of the central advocacy of the IDEA cohort collaboration, which I know we're going to hear about more today. He's the author of more than 350 peer-reviewed papers. I don't know how you slept the last one. And he's also the associate director of the Einstein Rockefeller Team CPOD. Prior to joining academia, he worked in public health practice as an epidemic intelligence service officer, CDC, and HIV and surveillance at the New York City Department of Health and Hygiene, is where many of us first met Denis. He's been quoted regularly in the New York Times, The Guardian, Associated Press, CNN, Rolling Stone, Washington Post, I won't go on, the list is long. He also appeared on NPR, NBC, CBS, NYC, and the Brian Lara Show. All right, I'll finish. He was recently named the 2025 to 2026 Koch Bill Distinguished Chair in Public Health to deepen research, weather-driven health impacts. Before you come up, I have some sobering news on Halloween related to climate. Just yesterday, the New York Times reported about how drought, extreme heat, and irregular rainfall patterns have suppressed cocoa yields in West Africa, primary growing region. And they learned that chocolate has quietly disappeared from the packages of almond joy, Mr. Goodbar, and Rolo. This happened because companies have cut costs by replacing cocoa butter with other oils. Because of this, these candies no longer meet the FDA definition of the health problem. But that's a little Halloween news for you. And I'd like to welcome
Thank you for that great introduction, Tim, and thanks to the school, to the Epi department and the Institute for having me here today. I hope it's coming through loud and clear. I've had coffee, I've had my chocolate bar. I'm like so ready to go. And the motivation for the talk, well, actually, let me get my thing here. These are my disclosures. I'm on sabbatical right now, and as Tim mentioned, one of the things that I'm going to focus on as a research priority during my sabbatical is to is to grow our research in this area, looking at the causal effects of not just extreme weather events on health outcomes, but large scale exposures such as extreme weather events on health outcomes. And so that's a big part of the motivation of this talk. In particular around extreme weather, I think that these events may be an underappreciated cause of poor outcomes as it relates to HIV, and underappreciated determinants of other health outcomes. And so, as many of you know, HIV is a driver of a lot of deaths and morbidity globally. Tens of millions of people around the world rely on, daily access to HIV medications for treatment, for prevention. And the climate change, as Tim alluded to in his opening remarks, it's not, the world is not going in a direction that is ameliorating it. It's continuing, in many ways unabated. And I think a point here is that public health programs and the approaches that we use need to jump into this reality with both feet and adapt our programs, adapt our plans to focus more on resilience, to focus on dealing with and minimizing or lessening the impacts, health impacts of climate change. And of course, this this is something that is going to look different depending on which health outcome you're focused on, for HIV or TB or for diabetes or cardiovascular disease, what have you. And so that makes it important for public health research to begin to understand the ways in which the climate-related determinants of health outcomes, as well as the mechanisms by which these determinants are operating. This can help us then move into the next phase to identify those strategies that are going to be working to help lessen the impacts of what is going to be a very hard, difficult times, especially in certain parts of the world that are most affected by climate change. So in the talk, I'll cover the international epidemiology databases to evaluate AIDS cohort collaborations. I'll talk about, I'll draw on some examples of studies that we've done within IDEA to look at the causal impacts of large-scale exposures on HIV care outcomes. And then I'll get into some of the motivation, a little bit more detail than I'm talking about here, about why we decided to move into looking at the effects of climate change and extreme weather on HIV outcomes. And then I'll talk about an R01 that we have that is still alive and well, thankfully, focused on looking at the impacts of extreme weather on HIV outcomes, called the Weathering HIV Study. So I think about the work that we're doing here as like part of a category of work that aims to characterize the causal effects of large-scale exposures on health outcomes. And unlike, I know I'm at a school of public health, so I don't really need to say too much about this, but like unlike individual level exposures like diet and smoking and substance use, the exposures I'm talking about here in this talk really sort of operate above the individual level, at the level of communities, regions, or entire communities. And so, examples that I'm going to try to touch on each of these: national policy changes, pandemics, funding cuts, climate shocks, of course, and I guess the other things that I'm not going to really touch so much on, but like ubiquitous environmental exposures like lead and like where we've had great success, and microplastics, which seems like a huge mess, and I don't know how we're going to get through it. So this type of research, I think, often has direct policy relevance. The large scale exposures by nature are systemic and often modifiable through policy choices, through funding priorities, and preparedness strategies. And so quantifying their effects is really sort of essential for prevention and resilience. By definition, these exposures affect large numbers of people simultaneously, and that means even if the causal effect of these large-scale exposures at the individual level is small, when you look across entire populations, the effect on population health can be enormous. But these exposures are also really challenging to study rigorously because everyone or nearly everyone, has the exposure at the same time. It's hard to find suitable comparison groups. And many of the exposures can, they don't just occur at one point in time. They can evolve gradually. They can be episodic in nature, thinking about things like droughts and pandemics. And that makes it difficult or challenging to design good causal studies. Another challenge is measurement. Many of the large-scale exposures aren't easily captured at the individual level. You can't measure rainfall or foreign aid suspension at the individual level the same way you can measure blood pressure or some other individual level factor. And the mechanisms, of course, are quite complex or can be quite complex. Multiple pathways working through health systems and the disruptions that happen to them, economic shocks that happen outside the health system but ultimately affect the health system. For example, food insecurity, migration. These are all complex, multiple pathways, and disentangling them is critical for us to understand, which interventions can be most impactful at lessening the impacts of climate change and extreme weather. I have to pause here because I have and do believe that climate change is really important from a population health standpoint. But it's impossible not to acknowledge what's been happening with U.S. foreign aid and the impacts that that's having, which are far more severe at the moment. And I think this is where it began to sort of come together to me, like the importance of looking at large scale exposures. To me, this is like the worst. You can think about what's been happening with foreign aid in different areas around the world as like an extreme weather event that happens everywhere all at the same time for a really long time. And this is the worst kind of scenario that we could be facing. I don't. So by talking to you about extreme weather and HIV outcomes, I still think it's really important for us, for reasons I mentioned, to move forward with this work. The work is still important in my mind, but I just want to acknowledge that we have also other work that we need to be focused on, and we also need to delve into this and understand the document and understand the impacts of these funding cuts that have happened, that have estimated by these modeling studies here to have impacted caused more than 130,000 deaths just since January 24th. So next, I want to just talk about a lot of the work I'm going to present is based in the idea collaboration, and so since it's so key, I'll give a little background on IDEA so that you guys know a little bit more about what it's about. So IDEA is an NIH-funded multi-regional cohort collaboration. As Tim mentioned, I work in the Central Africa region, and there are 6 other regions that are funded separately by NIH, and we collaborate together. We pool our data. We do our research in our own regions, and we also do multi-regional work. To put it in perspective, the IDEA database represents data from about 44 countries around the world, 750 clinics providing routine HIV care, and 2.3 million patients to date have enrolled in the clinics that are participating in IDEA. And the data go all the way back to 2004, right around the time where we were moving into the emergency phase of HIV treatment scale up in many settings around the world. IDEA also has several working groups with sort of deep expertise around things like cancer, TB, clinical outcomes, and mental health and substance use, which we can draw on to support the research agenda that's happening across all the regional collaborations. So going into some examples here, this is the guidelines and policy type exposures. We've spent quite a bit of time in IDEA looking at the impacts of guideline expansion. And over the years, for those of you that are not in the HIV field, the World Health Organization has put forward successively expanding HIV treatment guidelines over the years about when people should be eligible to start HIV treatment. Starting with, those having the most advanced HIV disease in the early part of the scale up, gradually expanding over time between 2006 and 2015 to include people that have less severe disease, culminating in sort of what I call the treat all phase of guideline era, where it was recommended by WHO that anyone with HIV should be treated immediately upon diagnosis or within 7 days. And this slide, the map here shows, so WHO puts out the policy in the guidelines in 2015, and the map shows the implementation of treat all policies at the national level by mid 2017. And you can see that most countries around the world had by that time begun implementing treat all policies as part of their national programs. So this set up an opportunity for us in IDEA to begin to look at some of the potential, the implementation of these policies and their potential impacts. So it's one thing to have a national policy. It's another thing to sort of actually have practices in place at each clinic where their policy is being implemented, but such that everyone coming through the door is being treated as soon as possible after enrollment in care. So IDEA routinely does site level surveys every few years, and when we happen to be doing one right around mid 2017, and we added questions about treat all implementation to that site assessment, and so we were able to ascertain, for example, at IDEA sites at least, by the end of 2017, 91% of our sites had been implementing treat all policies. And it was, mostly near universal across regions. Some regions were slower to adapt. So this was suggesting that treat all policy implementation was happening at the site level when you survey individual sites about their practices. So another question is, well, is this influencing? Is this having an impact on patient outcomes? And so we did another study that looked at the patient level data to see the extent to which treat all policies were resulting in more rapid treatment initiation after enrollment in care. For this analysis, we focused on the 6 countries that were among the first to have post treat all policy implementation, data on post treat all policy implementation. It was about 6 countries with 814,000 ART naive patients who enrolled in care over a very long period of time. And our primary outcome was rapid ART initiation. So what proportion of people initiated treatment within 30 days after enrollment in care? And this was a new approach for us, was to use quasi-experimental methods. So we used a regression discontinuity design, which is just to say that it's a method that takes advantage of the fact that at a certain threshold, in this case, the day or the week of treat all policy implementation at the national level, that there's randomness in the characteristics of the people enrolling before and after that time threshold. And that randomness allows essentially a natural experiment that you can then consider any effect that you see before and after the threshold as a causal effect. And so we deployed this approach. Actually, I should have said, two of our doctoral students, Olga Tomajczyk and Ellen Brazier, did this work. We were not teaching this method in our PhD program at the time, but we were teaching students how to be able to learn new methods. And Ellen and Olga jumped in and took on regression discontinuity as an approach that they thought, and I agreed, would be good to use in this situation. And so I'm going to walk you through the findings for Rwanda here. So this applies to some of the rest of the slides. Many of the slides I'm going to show you later too. So on the y-axis is the proportion of people that are enrolling in care, everyone coming through the door. that initiate treatment within 30 days. And you can see over time, these are the different periods of guideline expansions that I alluded to earlier. So about in 2006 and 2007, about 30% of patients were initiating treatment within 30 days of enrollment in care. This was kind of steady and maybe slightly increasing over time. But the guideline expansions really didn't influence things that much until we get to treat all policy expansion with the national level, happened in July of 2016 in Rwanda. We see a really dramatic jump in the proportion of patients who initiated treatment within 30 days. And then after that, a pretty steep continual increase in that proportion over time. So moving towards treat all. And looking at the other countries, we saw similar patterns, different magnitudes of the change, different slopes, but certainly an interpretation here is that treat all policies at the national level caused more people to be able to initiate treatment within 30 days rapidly, and that policy appears to be sustainable after the implementation. The other two sort of patterns, or one pattern we saw was not necessarily an immediate discontinuity or jump in the proportion, but a change in the slope. In this case, happening even a little bit before the policy began implemented. In this case, as soon as the policy changed in Uganda, there was a rapid change in the slope. We also were interested in, potentially negative effects of treat all policy implementation. Anytime you think about the health effects of policies, you have to think about, things like, unintended consequences. We were worried that there was a possibility that with more people being eligible for treatment, that sicker patients could be crowded out. I'm not going to present that here, but we didn't find evidence of that. But another analysis we did was to look at the extent to which treat all policies were changing the rate of CD4 testing prior to treatment initiation and viral load monitoring after. These are essential parts of HIV care delivery. And these is sort of the same kind of graphs that I showed you before, looking at the policy timeline adoption across this time 26 countries. In the green, we have high and upper middle income countries, and in blue, we have low and lower middle income countries, so ideal sites in these settings. And then we also stratified by age. We have adults, adolescents, and children. And then we have up here is CD4 testing prior to ART initiation, and here is viral load monitoring after. So you can see that there was an impact of treat all policies, a negative one on CD4 testing prior to treatment initiation. And that this was a bigger effect in like resource limited settings. We didn't see much of a change in the viral load monitoring after ART initiation, although it is slightly on an increasing trajectory, which was good. But in general, these rates should be much higher. But it's just to say that this is another example of looking at how policies impact care delivery and health outcomes. Another example of large-scale exposures that we tried to look at in ideas of pandemics. So in this case, the COVID-19 pandemic. There are many ways that the pandemic could have impacted HIV care delivery, for example, through restrictions that relate to travel and service provision and there are also some good things that happened during the COVID pandemic where some sites began to adapt to telemedicine or medication dispensing that is over longer periods of time to help prevent the need to go back and forth to clinics. And then there also could be stockouts as a result of pandemic impact. This was the result of a similar site survey that we deployed sort of in between the routine site assessments so that we could assess what the impact of the pandemic was on HIV care and treatment. And you can see that there were some impacts in these realms. And the West Africa region applied a regression discontinuity design to some of their sites. On the top here, we're seeing new ART initiations by country, and on the bottom here, we're seeing viral load monitoring over time. And for the most part, the story here was that while there were disruptions, sites tended to return back to their original trajectories. Even in some cases, like here in Burkina, it took a little bit longer to be able to get back into that trajectory. Another one that we're actively involved in right now in IDEA is looking at the impact of funding cuts. The first example I want to present is a modeling study that we've done in Central Africa. We developed years back a mathematical model to look at HIV care cascade outcomes that's calibrated to the Rwanda experience using IDEA data from Rwanda. And Rwanda, we thought, was an important country to focus on for this analysis because it has been one of the most successful countries scaling up HIV treatment, maybe globally, achieving the sort of goals of 95% diagnosed, 95% treated, and 95% virally suppressed faster than almost anyone. The US is very far from that target. So the questions we wanted to sort of answer, like, well, if US government funding is eliminated in Rwanda for HIV treatment, how long would it take for the government of Rwanda to either, or could they stem the tide, or if they couldn't, how long would it take them to be able to, reset and return to sort of outcomes that were where they were prior to the impact of these funding cuts by for example, offsetting with resources that they come up with from elsewhere. And so the modeling exercise basically looks at, I'm sorry, all this is cut off at the top. I'm not sure what. But we look at, for example, the number of adults living with HIV, and when the funding cuts happen here, if Rwanda, the government of Rwanda can somehow sustain the level of, they can somehow sustain the level of resources, they can continue on the trend. If they can sustain 90% of them, this is the impact, and maybe more likely if they can only sustain 50% or 75%, you would see pretty large increases over a 10-year horizon in the number of people living with HIV, the number of deaths, number of new infections, and I think this is prevalence, and I can't see this might be incidence. There we go. All right. So, I mean, taking away here, even in countries like Rwanda that have achieved near epidemic control, the abrupt and persistent elimination of funding could really drastically reduce critical gains. We also launched another site survey. There's very little hard data coming out of the region about the impact of these funding cuts. So we did a survey to look at different domains that at IDEA sites. We had about 103 sites that were able to participate in, we had a subset of 103 sites that were able to respond to our survey about clinic disruptions. And what we found in this survey was that 47% reported any disruptions, and you can see them by sort of realm here. But the kinds of things, even things that were not supposed to be affected by these funding cuts, in fact, were being affected. This also sort of came through in some of the news reports from the sub-Saharan African region. We also, because IDEA is not just PEPFAR sites, it's PEPFAR and non-PEPFAR sites, we could look at we could compare the extent of disruptions at PEPFAR supported countries compared to non-PEPFAR supported countries. And you can see that this was an effect that was much larger in PEPFAR supported areas of the country, of the world. Given the dearth of data that is coming out on these impacts, we decided to launch a public version of our survey that anyone could, if they had knowledge of what was going on in an HIV care clinic anywhere in the world, they could fill out this survey and submit data to us. We launched this probably back in August or September. And I'm happy to say that between the two efforts, we've gotten over 120 or so responses representing clinics in about 42 countries around the world. I don't have the data to share yet, but if any of you are working with networks of HIV clinics, including in the US, and would like to have people familiar with those clinics take part in this effort, the link and the QR code is there. We'd love to have you be part of the effort. Okay, so now I'm going to jump into the extreme weather part of the talk. I want to say first, just a little bit of background and motivation for us. A lot of people ask me why would you focus on HIV outcomes in relation to climate change and extreme weather as opposed to other health outcomes. Part of it is that's the data I had access to, and you know, it really the IDEA network is really, I'll try to make the case that it's an ideal place to start. But of course, part of it is that there's real evidence to suggest that climate change could be an important determinant, not only of HIV outcomes at the individual and population level, but maybe even one that has influenced the trajectory of the pandemic over time. But of course, what you can see with this map of adult HIV prevalence on the top and the impacts of climate change on the bottom, you can see there's just ecologically geographic overlap between these two things. And again, just to remind you of the magnitude of the HIV pandemic right around now, 40 million people living with HIV, about 600,000 deaths every year, about 1.3 million new HIV infections. A colleague of mine, Sherry Weiser at UCSF, who works with us, co-leads this Weathering HIV project that I'm going to say more about, has developed sort of a framework, a conceptual framework about how climate change and extreme weather might impact the risk of acquiring HIV and the morbidity and mortality associated with HIV infection. And of course, pathways you see here are things like water and food insecurity, migration and displacement, increases in other infectious diseases such as TB and malaria, waterborne diseases, infrastructure erosion, and conflicts and violence. So these are some of the mechanisms that we are thinking about in our work. And this conceptual framework paper has really sort of helped set the stage. Since we started this work, there have been commentaries, and there's a recent commentary here in the Lancet HIV about how climate change could directly be affecting the HIV response and how it needs to be factored in. In general, most of these commentaries and systematic reviews are concluding that the effects of climate change on HIV are really poorly understood, poorly characterized. Related to this, our team in getting into our work around extreme weather and HIV outcomes, we felt it was important to undertake a systematic review to understand how investigators in this space are actually operationalizing climate-related exposures in their studies of people with HIV. So these are some of the research questions that we're asking. This work is being led by our postdoc, Sophia Arabagis, and we're pretty far along. In the systematic review. It's not published yet, but we hope to probably submit that in the coming months. These are some of our research questions, and I'll just quickly go through some of the findings so far. So we started out with about 3,000 studies that we found through different searches with our keywords, and ultimately, in terms of the studies we wanted to include, these were studies that would connect an extreme weather exposure to an HIV-related health outcome in a population of people living with HIV or a population at risk for acquiring HIV. At the end of the day, we found 85 such studies that were further further examined. And just as an exemplar, I'll just highlight one of these studies. This was a study in Southern Africa that was, many of the studies in the literature are cross-sectional in nature. And so the need for longitudinal studies and longitudinal data is really, really great. But this is an example of a longitudinal study that looked at the effect of a drought that has been going on in Southern Africa for several years on the impact of things like all-cause mortality, unsuppressed viral loads, and gaps in care. And they did find, associations here such that suggesting that drought could negatively impact HIV treatment behaviors and outcomes. And in terms of, I'm not going to go through all the preliminary findings of our systematic review, but I'll just hit sort of the bottom line here. Many of the related reviews published recently that have been published recently on the impact of extreme weather on things like adherence and things like that, but nothing specific to our research questions. And in general, even these reviews and our reviews sort of showing the evidence base is increasing, but really fragmented. Very few good causal or longitudinal studies out there. And big takeaway is the need for more rigorous longitudinal designs with consistent exposure definitions. So this review has really helped us in our work on defining exposures in the IDEA collaboration as it relates to extreme weather events. And so in many ways, the IDEA collaboration is sort of ideal for this kind of work, given, again, coming back, this is kind of review for you now, but 700 clinics, 44 countries, more than 2.3 million people enrolling in HIV care, and data going back as far as 2004. So the way I think about that now, and why I thought it was important for us to potentially do this in IDEA, is if you think about those 700 sites and the context, the varied context in which they all exist, and then imagine the number of extreme weather events that may have accrued at all of those sites over a period of time from, say, 2004 to 2024, there's the potential to examine the effects of extreme weather exposures in IDEA is quite high, just because of the way our cohort is structured. So we wrote and resubmitted and several times an R01 to actually do this work, and it took years, but we eventually got funded. We're in our third year. The Weathering HIV study is in its third year now. I'm going to hit on some of the design issues, the data we're using, and I'll show you some very preliminary results from the work. The first is what has been the bulk of the work for us, is leveraging climate data to use as epidemiologic exposure in some of our analyses. These data on daily data that exist publicly available on precipitation and temperature with pretty good geographic and temporal resolution. We began working with colleagues at UCSB who do this for a living. They produce a data set in this called chirps and cherts, and these are, I'm going to explain what these are and how we're leveraging them. And hopefully this works. Much of it comes from satellites, so you can imagine like the satellites orbiting the Earth, and there are some that sort of are stationary and rotate with the Earth, but they're getting infrared data and electromagnetic data from the Earth's surface and atmosphere that allows basically as indirect measurements of temperature and rainfall. And over the course of a few hours, you can see how all these satellites combined really covers the entire planet, not just the land mass, but also the ocean. So in this way, there are massive data sets that are compiled that reflect temperature and rainfall at every point on Earth over a given day with 5 kilometer resolution. These data are indirect measurements, right? Imperfect, and many of the teams that compile these data sets, such as the team at UCSB, they also rely and combine that satellite data with more direct measurements, such as those from weather stations around the world. Like think about a weather station that might be at an airport that is gathering routinely temperature and rainfall and humidity and things like that. You can see the density of these things, of these weather stations that are around the world that are being drawn into the CHIRPS data set that we're using. One thing that comes across is that there are some places where it's really dense and other places where it's pretty sparse, and that calls to mind the potential for sparse data and data quality issues in certain parts of the world, especially in places where a lot of our work is focused. But when you combine the satellite data with the weather station data, they do produce more accurate, more stable estimates, and so that's what the CHIRPS data are. It's a combination of these two things, and there's been good validation work to suggest that these data, are valid to certain levels of resolution. And I might be going into too much detail here, but I just want to do it because it highlights, how you get from a daily measure of temperature and rainfall in a given area into classifying something as a period of drought or a period of heavy rainfall. Basically, these satellite data go all the way back to 1980. And so there's a historical trend. And this is where a lot of the climate change measures come from, the historical data that goes way back in time. When you compare what's happening today on a given day or in a given month with historical trends going way back, you can see how much it deviates from, I wouldn't call it, I guess you can call it the normal distribution, the Z-score distribution, say, of rainfall. And so if this represents historical data, you can look in a given month. And what we did was we took the three, what are typically the three wettest months of the year in a given geographic area. These are the months that are critical for crop yield, to have good rainfall for good crop yield. When you look in those three typically wettest months of the year, or in the wet season, compared to historical trends, and you observe dry months along this distribution, you can have, what we then classify as non-drought, drought, or extreme drought conditions over the course of, say, in our case, we were doing 30-day cumulative rainfall estimates. So we look on a given day or in a given month, where patients are receiving services, and we compare that period to historical data, and to decide if it's a drought month or not. And then if this is an HIV clinic, if we're looking at extreme rainfall, we've been using 25-kilometer buffers. And if we are looking at drought, we've been using 100-kilometer buffers. Each one of these pixels represents 5 kilometers. And so we average what we're seeing in all of the pixels over the course of a month to get a data point for rainfall and drought in a given month. And so these data are combined, clinic data and climate data, with longitude and latitude, and that allows us to sort of get a sense of the burden of extreme weather at IDEA clinics around the world. All of a sudden, just through matching our cohort data with these climate data, we're able to now know something about what the extreme weather experience is in our IDEA cohort. So the weather in HIV study, I'll go through the aims quickly. We want to characterize the associations, the causal associations between extreme weather events and subsequent HIV care outcomes. Some of the outcomes we were able to look at in IDEA are listed here. Things like rapid ART initiation, routine viral load monitoring. I kind of showed you some of the ones that we've been looking at for other studies, then we're using similar ones here. We have data on TB treatment that we can look at. We have data on body mass index, which is relevant for food security pathways. And we have data on, we will be getting data on mobility from other data sources. We don't have that in IDEA, unfortunately. But these measures are sort of setting us up to look at some of the pathways I mentioned. Aim 2 is really focused on delving into mechanisms. So it's a mixed methods aim. Partly we'll be and I'll come back to this if there's time near the end, but we'll be doing like key informant interviews, not only with patients and providers, but with entities in government that are responsible for example, emergency preparedness and in some cases, you know, climate task forces that exist to understand the extent to which there's, you know, there are already interventions and policies that are being considered or even implemented that we need to know about. And then we'll use the IDEA data to do some quantitative analysis informed by that qualitative work to understand mediators and pathways. Because it's such a big data set, we can do a lot of stratifications. And so you can imagine that some people with HIV might be more vulnerable to climate shocks than others. So people with advanced HIV, people who are new to HIV care that haven't yet established, you know, haven't yet established their care routines, people with co-infection, infants and adolescents, pregnant and recently postpartum women, for example. And then, you know, sort of on the stratification side, we can also look at different types of extreme weather events, you know, hurricanes, droughts, floods. We can look at how the effects of these different extreme weather events vary by location. And we can look at the extent to which, you know, food insecurity is playing a role. So here's some of the data on drought from that we've produced. So I'll orient you. How many people have heard of a guy named Edward Tufte? Okay, yeah. So I took a class like when I was with the health department, like 20 years ago, and one of the big things he was like, you know, you visualize your data, have as little white space as possible, make as much, you know, try to condense as much into a little space as you can. And so this is showing basically each one pixel going across here is a clinic, an idea. And this is going back to 1981. And each time you see a mark, it's showing that there is a drought period during one of those 3 wettest months of the year. And the color of the color of the mark represents the intensity of the drought. And so here you can quickly see that over the course of these, you know, 40 years, the burden of drought and even extreme drought at IDEA clinics, and you can get a sense of the geographic clustering because some clinics are close to each other. You can get a sense of regional clustering. So we've got it organized by region here: West Africa, Southern Africa, North America, East Africa. This is Latin America and the Caribbean, Central Africa, and Asia Pacific. So this all in one snapshot, we have a quick sense of the drought experience at all of IDEA clinics. This is something that the Tufte course made me try to strive for, and I think it's been a good result. But now that we've been able to characterize drought, we can begin to look at the burden of drought over time and how it's varying by site. So this is Asia Pacific region. You can see that cumulatively over time, you know, about 20%, or there have been about 20 droughts on average. The dark line shows the average for all of the different sites, which are the other lines here. So you can see how the drought trend looks over time across IDEA regions. We did an analysis where we drilled in on Central Africa. We're beginning to do the first work that is correlating extreme weather exposures with HIV care outcomes. We focused just on Central Africa here. And now what I'm showing you is individual clinics. So at this clinic, you can see the monthly patient visit volume. So people coming through the door, the number of people coming in any given month. And each of these bars represents a drought period. And the shading of the bar represents drought intensity. So it's hard to really appreciate like any associations yet. And there may or may not be anything here. But it's just to say that we're beginning to do these very basic correlations between climate data and HIV care outcomes in the IDEA network. I'll just give you a quick sense of the qualitative work that I alluded to. We're working in the Philippines and Rwanda, 2 very different settings, but both very much affected by extreme weather in different ways. And you know, we're just really kind of learning, hopefully from an implementation perspective, not only how extreme weather has had an impact, but what are some of the strategies, formal and informal, that patients, providers, and governments are considering or already implementing to address the increasing threats of extreme weather. And so, yeah, these are some of the details in terms of the numbers. We've already completed the first. We already completed all of the data collection. We're in the process of coding now. So I'm getting close to wrapping up here. Where we are, next steps, we're going to be completing our systematic review, hopefully in the next few months, completing the coding and analysis of the qualitative data, and working to better understand the temporal patterns of different exposure events, extreme weather exposure events across the IDEA sites through some of the visualizations I showed you. So that will involve, another thing we're doing is we're pulling in other data sources besides the satellite and weather station data that I mentioned. There are other data sources that we want to be able to triangulate and assess the extent to which different data sources are telling the same story in certain geographic areas. And then that will help us sort of finalize some of our exposure definitions for the analyses we plan to do in the future. We're also going to be working on identifying the best modeling approaches. One thing that we learned pretty quickly is that the regression discontinuity approach, while great for a lot of the work that we've done, is not going to be the sort of what's the right word? The tool that we're going to be able to use for all of this. So there are other designs that we're looking at, such as interrupted time series and differences in differences. We've got a great causal inference team at CUNY. Zach Sean is our biostatistician, and he's developing structural nested mean models to allow us to look at the effects of drought over time. And we're also even considering sort of target trial approaches. If you're familiar with the Miguel Hernan team, that target trial framework, we've been applying that framework to many different studies in our portfolio, and we're going to do them for the extreme weather portfolio as well. So this is an AI generated image, my first attempt at generating an AI. And I talked about the things that, I'm thinking about as it relates to climate change and health outcomes, and this is what it produced. It's kind of scary. It is scary. It also, I don't want to say that there's, everything's going to be great at the end. I don't think that sun in my mind represents that, we're going to get to the other side of it. But what it does represent to me is that I think we can get insights and understanding about how to adapt and limit the effects of climate change on health. Obviously, not completely, but to some extent. And to me, that's the light at the end of all of this. And a big part of that, in my view, is trying to advance causal studies for the effects of EWEs on HIV and many other health outcomes, so that we can minimize the negative impacts that are already affecting us pretty severely. Sorry, that's just an extra slide. I mean, just to acknowledge like the many people who are part of this work. There's the Central Africa IDEA team, a team at the CUNY Institute for Implementation Science and Population Health, our teams in Rwanda and in the Philippines, the team at UCSF led by Sherry Weiser. We have colleagues at UCSB for the climate data, and of course, our NIH colleagues who have been instrumental in supporting us through IDEA and also through these very difficult funding, for this very difficult funding landscape over the last several months. Thanks for your attention, and I'm happy to take any questions.
Take questions in the room first, and then I'll have folks online can use the chat feature.
I think there's some chat.
Facial regression discontinuity is a comment.
We have a question.
Yeah, I had a question. What, in your opinion, makes Rwanda uniquely successful at hitting those targets for like HIV diagnosis, treatment, and viral load?
I think there is just something very unique about the setting. It's highly organized. There are efforts to the political commitment is to HIV treatment scale up is super high. Well resourced in terms of the what the government of Rwanda can bring to the table, which is human resources and infrastructure has been really high. I think there's also a culture of following directives at in the public health system and in the population that I think has been a big part of it. It's just not something we see anywhere else in the region to that degree. Michael.
So, general question is, why drought with HIV, particularly when things like temperature may be a little bit easier, quote unquote. The indications of drought to health are quite complex when you look at climate change. The temperature might be a little bit, again, quote unquote, easier to look at. Same with the opposite of drought, extreme precipitation. Just sort of wondering, are you eventually going to look at those, or sort of what was why did you choose drought first to look at?
Okay, so we are looking at all of them. I should have, if I didn't say that, I meant to. I probably highlighted drought because that had been the bigger challenge in terms of the exposure variables to operationalize for us. But I also think it's probably one of the more impactful extreme weather events. The main pathways, several of them are affected by drought. Food insecurity being one, migration being another, and economic security is another one. So we have, and they tend to be over very long periods of time, whereas heat waves, flooding, things like that are more. I think they have an impact, but I think they're more time limited. But we intend to look at all of them. But the most evidence in the literature. There's a lot of U.S.-based studies looking at the impact of Hurricane Katrina on HIV care outcomes. But in sub-Saharan Africa, drought seems to be one of the more impactful ones, and not only on HIV care, but the food insecurity also leads people to exchange sex for money or other things, and appears to increase the incidence of HIV. So it's an important pathway. Anya.
Thank you for a wonderful talk. We have so many aspiring public health people in the room. I'm just interested in hearing your thoughts on how you've built this incredible collaboration. It seems that there's so many parts of the collaboration, and you've built something that's durable over time with all boats rising internationally. And I just wonder if you have any words of wisdom for all of us about how you've created this.
Well, I can't take credit for I mean, like I'm part of a very committed, expert, specialized team of people like listed right here, and no single one of us could do this, and it really is the synergy that happened when we started to come together. And I think a lot of it is a result of so in an epi term, selection bias, right? This has been a labor of love for trying to get this work funded for probably, I don't know, 7-8 years. And so this is like who was left by the time we actually got the grant. It's the most committed, most very experienced team. And the fact that we're able to latch on to IDEA, which is a much more established collaboration, it's been in place for we're in our 20th year now. Really, I think is a great platform for a project like this. And yeah, we hope to be able to do more. Alan.
Yeah, along those lines, you've obviously brought together environmental scientists with infectious disease epidemiologists who don't ordinarily work together. And I'm curious how that's gone. What have people learned from each other? what sort of challenges have you found as you brought these different fields, the Venn diagram of these different fields together?
Well, the first thing I'll say, to me, that like, this is one of the reasons why I got into public health to begin with. Like, it was the idea that like I could work one day with an engineer, another day a surgeon, or another time. The multidisciplinary aspect of it, you don't always get it in the public health research that you do, but this project really truly is, and it's been so as much as it is rewarding for me to be able to learn from people that bring things I've never learned to the table. I think the same is true for them. And we've been lucky enough to find people who are like, for example, on the climate side, Frank Davenport and at UCSB, Chris Funk is another colleague of his there, and also our postdoc, Sophia Arabajas, finished her PhD in climate science and health geography at UCSB. They are a very even though they're climate scientists, they've been very health focused and even public health focused. So while they're not trained in epidemiology or what we're trained, it was pretty easy right away to work together and have those conversations. And even though they have different methods they might use to tackle the same problems, we're able to communicate and sort of get on the same page and ultimately put forward something that represents the best of the different perspectives on the team. So yeah, just very lucky. Amanda.
Thank you. Yeah, this has been an amazing talk. And as somebody who runs a cohort, I've been taking notes and had my team, some people joined a little late, but they got on. So I'm wondering, where do you go? I mean, I know you're just at the beginning of this, but I guess what are the potential impacts in terms of thinking about things like interventions, right? Obviously, I think everybody in this room understands the effects of global warming and those types of things, but are you thinking like interventions at the regional level, at the clinic level? Are you thinking about interventions yet?
Yeah. So I'll start with one that's pretty concrete. I read a paper recently from a team in Philadelphia that they found a pretty strong association with extreme heat and poor birth outcomes, and they developed a sort of early warning text system that warned people about it and what to do to avoid for pregnant people to avoid the effects of extreme heat. And like, that's an example of an intervention that I feel like is pretty scalable, pretty portable. And I'm sure there are many more out there that we don't even know about. Like, I feel like there has to be more in the way of systematic reviews to begin to pull all these things together. So I think so. Just to say that there's stuff out there already. In terms of what we're thinking about, some of the clues come from what we learned, say, during the COVID pandemic, the ways that clinics and programs adapted and had ART support groups where one person brings tons of medicine back to an entire community, or they prescribe for 6 months instead of 3 months or 1 month. These are all applicable and relevant. But I think the other, maybe at a higher level, we don't really know we haven't been able to quantify the effects of extreme weather on HIV care outcomes. And that means that funders, even though they're in it's a bad funding climate right now, but funders like PEPFAR and the Global Fund haven't been able to factor in climate change and extreme weather into their plans, their short-term and long-term plans. And what gets in the way of that is not having this rigorous information. And also that also means that mathematical modelers don't have it, and they don't factor that into their models that funders then use to make decisions about allocating resources. And so even though it's not an intervention at the clinic level, I do think that there's just by being able to consider the role of climate alongside other things that factor into the decisions about resource allocations is this kind of higher level intervention. And I mean, I think there's going to be a lot of things in between that we'll learn about through some of the qualitative work, but I don't presume to know what they might look like and whether we're going to get to a place where we can even test them in intervention studies yet.
Any other questions or comments from our folks in the room? Any questions?
I don't know, does anybody online?
Does anyone online have any questions? You can unmute yourself. I'm not sure if we'll be able to hear you. Otherwise, we'll use the chat function. But feel free to try. This is great.
That's neat.
I have a question. This is Jean Jordan.
Okay, great.
I'm curious about the evolution of sort of the point of care and newer diagnostic platforms and how that has maybe impacted the ability to more rapidly treat or diagnose and then treat individuals infected with HIV.
Yeah, so thanks for the question. I do think we've seen more point of care testing for sure. In the idea, we tend to see people after they've been diagnosed, and we don't really collect good data, unfortunately, on whether those diagnoses happen in the community or at the clinic on the day they enroll. So I can really only surmise that they've had an impact on getting people diagnosed earlier and linked to care sooner after diagnosis. We really have been only able to look at what happens after enrollment in care. But related to that, there's also rapid diagnostics for TB infection, and that I can say has had an impact on TB outcomes in a notable impact on early diagnosis and treatment initiation that we are able to observe an idea. But for HIV diagnosis, unfortunately, our collaboration is clinic based, so I can't say much.
Thank you.
Comment on Jean's comment, just to say for kids, the point of care early infant diagnosis has made a huge difference in terms of getting kids on care treatment in the diagnosis part. But also when these events occur, because they're closer to care, we have less sort of disruption from it takes 2 months to get a result back if they can do it there and they don't have to, the specimens don't have to travel.
Yeah, I mean, I certainly remember that time period where that early infant diagnosis was happening, took a long time to happen over long periods of time. And even that, an idea is a little bit limited because some of that is happening in PMTCT programs and not necessarily in the HIV treatment program. Sometimes they're the same for pregnant women. Oftentimes they're not.
Any questions or comments from our folks online?
Just wanted to say one last thing. That it's a great talk and really pushing us forward, I think, in thinking about methodological approaches to correlation as well as causal inference. I feel like we could sit here for hours and talk about the EPI methods. I realize the seminar probably should come to a close. We've been here an hour and 10 minutes, so I really appreciate you coming. And I'll be following up with you on some questions I have. But we really appreciate the chance to co-sponsor this EPI seminar with the department. For those interested in further activities with the Redstone Global Center, you can scan that QR code. We have a couple of events coming up in a few weeks in November having to do with our initiative on forced migration, climate, and health from humanitarianism from a policy perspective. We're working with the LEO School some of those discussions. So not EPI methods, but how to address some of the consequences of extreme weather events on health. So thanks again. This is really, really stimulating. Wrote a bunch of questions down.